we have seen that there is a multitude of devices and pumps on the market. And of course, there are obvious reasons for the availability of so many devices. For instance, we have devices for children, devices for small people, and so on and so forth. But does this varied selection of devices serve any other purpose other than a commercial interest by the companies? In other words, do we have any additional advantages to having so many devices in the market? Because it is confusing to the clinician and to the patient, especially in a country like Qatar where we have a small number of patients. We wouldn't possibly be able to compare 2 devices or 3 devices. So are there any advantages to having all these devices?
Well, I think clearly the answer is yes. If we could, let's say we had 10 devices that were available and that we had all the information that I showed you from Intermax about each of these devices, and that's one of the challenges because we're looking at many different devices and that complicates analyses and so on. But just for example, it's very attractive and sort of in the public relations world sexy to think about these very small pumps and very small incisions. But what if that incidence, the actuarial probability of 10% at 1 year with all these very small pumps was replaced by 0% with the Everhard? And it turned out that your probability of having a stroke was 0% with the Everhard, this bigger with this irrigation system and so on. So that may make a real difference. And so that these adverse events, I think what's very important to understand is that the differences between the propensity for each device having these adverse events are not necessarily equal, and this is unknown information currently. So I think the reason for competition is not to say who can generate another liter of flow, but who can generate a device which can minimize really critical adverse events, and that currently is wide open. So 5 years from now, I think we'll have more information that you can better select a single device for your hospital or your country.
Can I extend that question, please? All the information, bar very few, are derived from non-randomized trials. There have been only 1 or 2 randomized trials to my knowledge. And can you explain that to us? Why haven't we got head-to-head comparison between these trials? Because like you say, each device has its own idiosyncrasies, if you like, and peculiarities, and really to have evidence base, it's got to be randomized, or rather than matching and looking, should we have randomized, multi-center randomized trials?
Yeah, it's very interesting that ideally you'd think that randomized trials would be the goal of all device companies, of the FDA, but there are some drawbacks to randomized trials. Number one, they're very expensive, very expensive. And so if you have a company which is supported by venture capital, which many of these companies are, and they have to pay for not only their own device in a trial, but another company's device as well to randomize against, that is very expensive, and that literally almost doubles the cost of a trial, and that's very important. The second thing is the duration of time to complete the trial is expanded. And a year makes a critical difference as you're trying to facilitate the introduction of new devices into the field. So, in fact, the FDA has been quite imaginative in being open to using databases like Intermax to provide control patients for device trials. And in fact, the Heartware was the first company to actually get the FDA to use Intermax for control patients in their critical pivotal trial for bridge transplant therapy. So I think ideally most would agree that it would be a randomized trial, but there are some major financial and time-related disadvantages which encourage companies to use alternative methods.
Okay, yes, sir.
Thank you very much for your presentation, Mr. President. It's a clinical question for you. I'm Dr. Ali, I'm a consultant cardiac surgeon in this hospital. I've been working in the UK before I came here. And we've been using different devices. And since 2009, we shifted to hardware. There were three major problems we're facing at that time. It's the right-sided heart failure, the drive-by infection, and the anticoagulation post-surgery. What sort of anticoagulation we've been using? And my question is, what's your strategy for pump thrombosis after surgery? And if there's any protocol or guideline for anticoagulation post and live, especially hardware. Thank you very much.
You have a lot of good company with that question. People all over the world, all over Europe and the United States are really struggling with this issue because it's really the trade-off between strokes, and these are not embolic strokes, these are hemorrhagic strokes with continuous flow pumps and pump thrombosis. So, you know, it's clear that everybody needs Coumadin. Question about what the INR level is, probably 2 to 3. We all need some sort of antiplatelet protection. But I think the real clue is going to be finding better ways to identify very early fibrin deposition in the pumps. And that's what the focus of attention is in the United States and Europe, is trying to find markers for early deposition of fibrin, because if you can detect it early enough, usually through some hemolytic studies, you may be able to reverse the phenomenon, but as soon as it gets organized around an inflow bearing, you know, it seems inexorable that it's going to eventually, the pump's going to thrombose. And furthermore, we're just beginning to even think about, let alone understand, the different anticoagulation propensities of given patients for pump thrombosis. Whether thromboelastography would be useful, whether other more specific determinants of platelet function would be useful to complement the INR. So that's just a rather long-winded way of saying I don't know any more than you know about the
Thank you, Dr. Kakra.
Okay.
Amr.
Yeah. Well, here I need the expert opinion in this. You know, like as a transplanter, you know, like when you say the VAD survival will be in 24 months, will be 80%, okay, and then with good quality of life. And then when I look at heart transplant, you know, like the survival is still around 80% in 24 months. In heart transplant, we do biopsy, we give immunosuppression, we hammer the patient with steroids, and we got, you know, like the transplant, coronary artery disease, all kind of things you know, as expert in this, okay? So if we go for VAD versus transplant, okay, regarding quality of life, what do you think? Should we, you know, which quality of life is better if the survival is the same and both got side effects like the infection, the hemorrhage in the VAD, and the all things I mentioned for the transplant? So which is better?
Well, the first thing I want to say is that just remember, I'm not suggesting, or is any of this data suggesting that currently mechanical support is competitive with the average or the best transplant patient. It's not even close. I mean, you have a 10-year median survival of 50% or better with heart transplantation, and you don't have anything close to that ever demonstrated with a VAD. So we're talking about patients with multiple comorbidities who are less well suited for heart transplant that might be initially triaged. But just, can you imagine the degree of difficulty we're facing? So you're trying to get an adverse event burden. And, you know, it sounds good, it's a nice term about how to quantify. So now with heart failure, you're trying to equate the fact that he can't lie in bed, he has no energy, he's suffocating, to with GI bleeding and a stroke and a driveline infection, to recurrent biopsies, post-transplant lymphoproliferative disorder, opportunistic infection for transplant. So how do you equate all of that? It's going to be an incredible challenge to decide, well, what is equal to what? Because it's a whole different set of complications for each therapy. So I don't know how we're going to do it. We'll see.
So
one more thing. Okay, regarding still transplant again, for for if we use the VAD as bridge to transplant, as you know, we will sensitize the immune system. So with for transplant, if you bridge it as for transplant, then you have more adverse effect, or the longevity of the graft will be less because of the rejection, infection, which is more post-VAD for the transplant.
Actually, the most recent information suggests that a device itself before transplant may be a significant risk factor, but the magnitude of that difference is very small. And so I think that most of us believe now, based on more recent information, that it's a very low risk to the subsequent transplant to support the patient with a VAD as a bridge to transplant.
And the sensitization issue has been really almost refuted. And it was related mainly to the HeartMate 1 or but it was exaggerated. Is that right? I mean,
yeah, absolutely.
That
Yeah, most of our, the vast majority of patients are either not sensitized or sensitized with non-HLA antigens, antibodies now.
I have a question. And we haven't heard about the lack of pulsatility, and more evidence is coming through that while constant flow pumps can improve kidney function and other organ functions in patients with multi-organ failure, there are major disadvantages in terms of gastrointestinal bleeding, neurological problems. Carotid sinus studies have shown really differences. Is pulsatility not required physiologically?
Well, I'd say a couple of things. There have been so many studies with varying levels of sophistication that support whether it is or is not deleterious to organ functions such as kidneys. I think kidneys are encouraging. The data I showed you yesterday suggested the reversal of cardiorenal syndrome at least appears to be sustained. The two major areas which I think it's unequivocal that it does set you up, that it maybe not organ function per se, but GI bleeding. There's no question AV malformations are increased with non-pulsatile flow, and hypertension in the setting of non-pulsatile flow seems to be particularly dangerous for intracerebral hemorrhage. So I think those are the two big clinical factors which are very real with non-pulsatile or minimally pulsatile flow. But just another small comment about the reality is that if you could get a miniaturized pulsatile pump, it would be immediately competitive. But because of the expense of developing it and the fact that there's a huge amount of momentum now toward continuous flow pumps, it's going to be a long time before a miniaturized pulsatile pump, other than the total artificial heart, is developed, just because of the incredible bias now toward continuous flow technology, which is just a bit serendipitous. But I think those are the two areas that are really the Achilles heel clinically. The potential for strokes with hypertension with continuous flow pumps and GI bleeding.
Any more questions? Dr.
I'd like to ask about your experience. In if you put a LVAD for destination therapy, what is the chances that you extract the LVAD after a few years and the patient just doesn't need any more?
Bridge to recovery.
Yeah.
A bridge to recovery. Well, Dr. Yacoub has amassed, one of the most interesting experiences in the world, and it's interesting. For whatever reason, we have not been able to duplicate that experience in the United States, even in the setting of a multi-center trial. I think that there is tremendous interest in recovery. I don't talk about it from an Intermax point of view because although every institution, including our own, has a small number of patients who have miraculous recovery. But if you look at the actuarial likelihood of recovery, it's less than 10% of the implants that ever go on to recovery, those that are either destination or bridge to transplant. So I think it's, I won't say, use a phrase that Dr. Shumway often used about xenotransplantation. It'll always remain a goal in the future. But I do think that there are many, many challenges before recovery is going to be routine.
Can I answer the question? As I showed in my last slide, it is a challenge. It requires a massive amount of dedication in studying the patients from day one after transplantation. In your case, you have patients who have started the combination therapy late with improvement, but the repeated tests and the use of agents, be it pharmacologic or gene therapy or cell therapy, but pharmacologic in particular requires dedication. One of the problems, if you allow me, Jim, to say, in the United States is that you cannot examine the patients repeatedly without acquiring a massive bill, for example. And that is quite an impediment to bridging patients to recovery. And furthermore, systematically using drugs which helps reverse remodeling and physiologic hypertrophy. The thing is, what I've tried to show is that it is possible, and there are patients 10 years after explantation, it's proof of principle. And in our series at Hatfield, it was 65% of patients with non-ischemic cardiomyopathy having the combination therapy. It requires a massive amount of dedication and exact what you do, and further development in looking at what I was just looking at, system biology. You know exactly what to address.
And you know, one more comment about that is that these discussions about adverse events and controlling them or neutralizing them or preventing them is incredibly important to this discussion, because we all have, even though we weren't as successful as they were at Harefield, we all have patients which are dramatic examples of recovery. And so we all believe intuitively, and I think there's probably scientific evidence that Dr. Yaqub would know much better than I about earlier intervening within the heart failure syndrome, if you will. Earlier intervention increases the probability of recovery. That's why these adverse event eliminations is so important, because if you imagine a small pump in which you had few adverse events, put in earlier in the heart failure process, I can't believe that the probability of recovery wouldn't be progressively increased. And so, but in order to get access to that group of patients with equipoise, you can't have a lot of problems with the pump. And so that's why these discussions are really serious about neutralizing or preventing serious adverse events during the pump implant, is because you may then open the door to seriously earlier application and potential recovery.
Excuse me, sir.
Yes, sir.
My question has two short questions. Number one, regarding the RVAD. The indication is, does it indicate that all kinds of the heart failure, left side heart failure, pulmonary hypertension, so only the left, right ventricular failure?
Sorry, the question again? Can you repeat the question?
Yeah, the indication of the
About
RVAD.
Indication?
Yeah.
For using BIVAD or RVAD?
RVAD. That's indicated in all kinds of the right side heart failure, that left-sided or due to pulmonary hypertension.
So you're referring to the patient who has an LVAD, you're planning to put an LVAD in, or he has an LVAD? Or
Right,
you mean,
right.
Are you talking about isolated RVAD?
Yeah.
What's the indication for right ventricular
RVAD, yes.
insertion?
Left heart's okay.
Yes.
No.
The left heart is
No,
okay?
I mean, you said that the RVAD is indicated in the right side heart failure, yes?
And sorry, without an LVAD or with an LVAD?
No, without the use, I don't know, it's used alone or is combination usually?
Well, I mean, isolated right ventricular failure is extremely rare. And I think not really, it's not, isolated RVADs, for example, in Intermax would be 1% or less. So it's extremely rare. Temporary right ventricular failure, of course, is very common. But the greatest difficulty that the surgeons have in the decision making is if you have a central venous pressure of 22, pulmonary artery pressure that's 50 systolic, and your cardiac index is 1.5, and your wedge pressure is 30. Do you need an RVAD? And there's tremendous differences in opinions about that, but I think that by and large, there are no good predictors of when you're going to need an RVAD, and there are a lot of papers that have been written in, but they're not totally predictable. But I think that's one of the reasons that the Abiomed company has made an important contribution with their right ventricular assist device that can be put in through the femoral vein so that it's not very invasive, because the likelihood of return of some right ventricular function is high. But there are no really clear indications, except just in general, the higher the CVP is above 20 when you put the LVAD in, the greater the likelihood is that you're going to need an RVAD.
Yeah, second question is which is better than intra-aortic balloon pump or Ambella and management of patient with cardiogenic shock?
Sorry, the question again?
I mean the management of patient with cardiogenic shock. Which is better to use the intra-aortic balloon pump or Ambella device?
Oh, I see. Patient in shock.
Post-myocardial infarction or?
Yes, post-myocardial infarction. Yes.
I think the intra-aortic balloon pump is relatively ineffective for patients who are in shock. And you need mechanical support. I mean, just as a general statement.
There has
Someone
been a
impella.
recent trial, showing exactly that.